Hi, this is Healthfully Speaking. I'm your host, Dr. Brenda Andrew, a psychologist in the Middlebury area. I will be bringing you a series of programs dealing with health issues. Today we have a very special guest, Margaret Hutchinson Bates, who is a clinical mental health counselor.
That's right.
And I believe she practices in Middlebury and Burlington and maybe even wider area. Could you tell us a little bit about what you do, Margaret?
Well, I have a practice here in Middlebury, and then on occasion I do intensive weekends for women called Healing the Heart of the Inner Child, but I don't have a practice in Burlington.
Oh, okay.
So, yeah.
Well, that sounds really interesting. So you said you do some workshops on healing the inner child?
That's right. I do a lot of work with adult survivors of abuse, and one of the things that I have found in my own healing process and in listening to people about their healing processes is that taking some time out to have a retreat that's not necessarily in a hospital setting, but is an alternative to a hospital setting where there are therapists available and even a nurse available if needed. And this is always in conjunction with the client's therapist, if I don't happen to be the primary therapist. And the woman can take a weekend to go and really reflect on where she's at in her life right now and what has happened in the past so that she can integrate past, present, and future. And I do a lot of work with nature, helping people to get out into nature and to really get their feet back on the earth. So it's really been fascinating to me to do this work because I find that people are very responsive to this alternative kind of therapy in which they can have an intense experience in a safe setting and a healthy setting. Like we're very careful about the food and prepare really good meals that are vegetarian meals usually and simple meals, and people like that too. But the kind of therapy that happens in that setting can be very powerful. And a lot of the program that I developed comes from my experience with Native American and Buddhist traditions.
Okay. So you said a lot of the program has to do with Native American and Buddhist traditions. In what way are they implemented in this? Is it a therapeutic workshop that you're giving?
Right. In the Native American and Buddhist traditions, there's a lot of emphasis on connection with the earth and connection with all of nature, rather than a separation and a sense of not belonging. And particularly for survivors of abuse, they feel very separate, and they've had a lot of hard times in their families of origin usually. Although survivors of abuse could be someone who was recently raped or experienced something like that. But the Native tradition really helps people to think about their connection with not only other people, but also with the earth and with the sky above and with all creation. And we talk about the sacred medicine circle. And when I explain that to people who are hurting and help them to understand a little more about themselves in a different kind of context, they can see it almost as seasons passing in their lives. And it's a more hopeful message that helps them in their healing process, to think that this may be a season in their lives where there's a lot of difficult pain and sorrow and anger as they remember what happened to them and as they heal that.
It's very interesting. How long are the workshops?
Usually start Friday afternoon and end Sunday afternoon.
So it's like an intensive. You go from maybe when you first wake up in the morning until late at night.
Right.
Is that tied into, I've read a lot about, I may get this wrong, but I think it's called sweat lodges, where people go in and they have steam steam coming off of rocks.
Right. There's a very sacred native ceremony called the sweat lodge, and that's not something that I do. That would be something that if someone's interested, they would have to go to a Native American elder and request that ceremony to get the really sacred ceremony.
Well,
I think some people do it sometimes and call it a sweat, but it's a very, very special sacred ceremony.
Well, it sounds like from what you're saying, a lot of what you do, or at least in this workshop, has something to do with the Native American tradition. Where have you gotten your experience or your information from?
I've studied for a long time with a Cherokee grandmother and several other Native elders who have passed on certain of the traditions that come particularly from the Cherokee teachings and the crystal teachings, and some drumming and rattling and special chanting that is done specifically for healing purposes. So I'm empowered to do certain things along the way, and there's one ceremony that I've been practicing for a long time and have to practice on myself at least 100 times before the elders test me to see if I am ready. And it's interesting that a number of the Native American sacred ceremonies are not ever to be given to white people, and that goes for practices too, certain practices that the natives do. However, on the opposite side of the planet, the Buddhists, and particularly the Tibetan Buddhists, were practicing very similar healing ceremonies. So through the Buddhist tradition, I have been able to learn some of these traditions that my teacher cannot pass on to me because I'm white.
So where did you learn the Buddhist traditions?
Through the same School of Sacred Studies.
I see.
And also through some other Buddhist places that I have visited and studied in and gone to for retreats.
So how does this figure into, you said that you're in private practice also. How does this figure into the private practice that you do?
Well, I started out as a nurse. When I was a little girl, I wanted to be a nurse, and I went to the University of Vermont School of Nursing, and toward the end of the time when I was supposed to graduate, I suddenly realized that I didn't want to be giving people medications and shots and so on, and I felt a different calling. And then I realized it was people's minds that I wanted to work with. So that was when I began my training in psychology and first became a child psychologist. But it was not until many years later that it became really clear to me about why I suddenly didn't want to be a nurse. And that was when I had a diagnosis of cancer. And that was about 12 years ago. And I knew the medical route for cancer, and I knew what my options were. And I really didn't want to pursue that any further. And I want to make it clear that I very much respect the medical tradition, and I wouldn't be alive today without a lot of medical treatments that I've had. But I wanted to add to my repertoire of possibilities and alternatives the use of imagery. And it was at that time that the Simontons were doing a lot with imagery. And I looked to the Eastern traditions to help me understand more about how to use imagery and how to use breathing techniques to relax myself and to help the healing process to happen. So in my private practice, I started helping other people who had various diagnoses, whether it was cancer or, might be stressful situations, or it might be pending surgery, or many different medical things that might be going on with a client. And I worked in conjunction with their physician to help the healing process. And it's very powerful to help people use imagery along with whatever medical or other alternatives they're using in their healing process.
So you're saying now you use imagery in your therapy with your clients?
Sometimes, not all clients. Some people don't respond to that particular way of knowing themselves and of growing in the healing process, so I don't use that with them. So it depends on what the client comes to me for, what their main concerns are, and what is helpful to them.
So in your private therapy, you use some of the educational ideas you've gleaned from the Native Americans, the Buddhists,
and
imagery,
the medical model.
yeah,
Right.
imagery, medical model. What are some of the other kinds of things that you use in private practice? It seems like you have a variety of techniques.
Well, there's cognitive therapy and brief therapy, which helps people take a look at how they're thinking and how to problem solve in a different way. And that can be very empowering for people in just a few sessions to learn to think in a different way. For example, sometimes people don't really have a lot of awareness about the tendency to overgeneralize. And they're just like, well, all people are like this, or I hate all people who say this, this, and this to me. And it really traps them. And once they get that it's the way they're thinking that's getting them in trouble and making them have the anxieties and other feelings that they might be having, can be very helpful to them.
So how do you see what you do compared to what mental health therapists in general are about? There is a you are a professional clinical mental health therapist, right? Could you tell me something about what you had to go through to qualify for that? I guess I'm asking a lot of questions, and hopefully not confusing you or confusing the audience. But generally, I guess I'm wanting to know what you had to do to qualify to be a mental health therapist, generally what that genre is, and how you see yourself doing what a clinical mental health counselor, I'm sorry.
Yes, the official title is clinical mental health counselor, and there are 5 different mental health professionals in the state of Vermont and throughout the nation, and that's psychiatrists and PhD level psychologists and master level psychologists, social workers, mental health counselors, and psychiatric nurse practitioners. So those are the different professions, and we each do some things differently. We all need to assess what's going on with our clients and why they're coming to us for help, and we all need to make a treatment plan. And that treatment plan might be quite different depending on what therapist you would go to, and that's not necessarily based on what their specific profession is. And I think that's really important for consumers to understand, that just because you go to one psychologist, it doesn't mean the other psychologist will be exactly the same, and the same with mental health counselors. We're all different. However, mental health counselors do have in their training a little more emphasis on education and on vocational concerns, so that we are prepared to help people from a more educational model rather than from there's something drastically wrong model and let's look at what the symptom is. So it's a more holistic approach that many mental health counselors might use. And we have to study all kinds of psychology, abnormal psychology, normal psychology, developmental psychology, personality theory, group theory, child and family therapy, and we have to take an exam to get licensed, and we have to have lots and lots of supervision, and all of those things are looked at by the certifying board before we're granted a license, along with the score on our exam. So that's...
So what does a license, what's the benefit of a licensed practitioner versus one who's not licensed? What does that do for you? What does that do for clients?
Well, I think the main reason that licensure was started in any state was to protect the citizens of that state from anybody who might just put up a shingle and say, here I am, I'm going to help you, and maybe not necessarily have the training that's needed to truly help that person in the best possible way. So it ensures that the license ensures that the public is hopefully going to get the best kind of treatment. And if that practitioner makes a mistake or does something wrong, and it happens, then there's an ethical board that can look over what happened and make a ruling on that and protect the public in that way. Somebody who's not certified or licensed is not being watched over by a board. So it's important that people go to somebody who's certified or licensed. And another reason is that insurance companies are usually national companies. So if a client has insurance and wants to have their insurance pay for their therapy, the insurance company would require that it's a licensed therapist.
Okay. Switching a little bit back to your practice, what kind of clients, what kind of issues do you normally deal with?
Well, I work mostly with adults, also with families, and work with issues that can be anything from, somebody's feeling like they have more stress in their life than they would like to, and they would like to learn some relaxation techniques and also take a look at the balance of work and playtime and what to do about that. And work with people who have, some very serious post-traumatic stress disorder related to either past sexual abuse or physical abuse that's happened, and they're just being flooded with memories, or somebody who's been, say, raped or somehow victimized more recently. I help people who may have relationship concerns so that they can learn to communicate more clearly and more effectively in their relationships. So like that.
Could you tell me a little bit more about, of course without, getting into particulars, but be a more illustrative about maybe a typical situation of post-traumatic stress syndrome. I would imagine that some of our audience don't really understand what that is, and so just maybe walking through and talking about what a typical case would be like and how you would maybe handle something like that.
I think that people hear post-traumatic stress syndrome and they think, oh, that's Vietnam War veterans. That's when we first started to talk about that. But in fact, what we've learned is that many of the symptoms of having, say, flares of temper, or feeling very insecure, or not being sure what's real, or feeling mistrustful, or feeling concerned about keeping secrets and not understanding where that comes from or why, or actually having flashbacks, having difficulty sleeping. Those are some of the symptoms that somebody might come to me with and may not put it together that it's post-traumatic stress disorder, but know that something's going on that often happens suddenly. For example, a grown woman might come to me and say, I don't know what's going on, all of a sudden I feel really upset. She might say she's been depressed. She might say that she's been suddenly getting very angry with her children with great frequency, and she doesn't understand why, or all of a sudden she doesn't want to have a sexual relationship with her husband, and something's just happened. And in the course of the work, memories may start coming back after 30, 40, 50 years. I mean, I've worked with some people who are in their 60s and decide that they really want to heal something that happened way back when they were, say, 6 years old. And the course of the work that they do, I think of as a journey. And I'm there to guide them through that journey. I don't have a specific prescription for them or formula for them that if they just do this, and this, then their quality of life will be better. I don't know. What I do know is that if I make a commitment to journey with that person and to guide them and to be there for them in the ways that I can be, that's often the most reassuring and helpful thing to a survivor than anything else. To have their experience validated, and to know that there's finally somebody there who they can learn to trust. And that means so much to someone who hasn't been able to trust, and hasn't been able to trust themselves either, because what we tend to do as human beings is to take on certain roles and play by certain rules that we were taught in the dysfunctional family of origin that may not work for us in our adult life, and yet we don't know what else to do. And usually what people do is continue playing those roles and doing the things that they know they don't want to do, but that feels safer to them because it's not as scary, it's not as risky, because they know the outcome. Even if it's a terrible outcome of a certain behavior, they know what's going to happen. It's the unknown that's scary. So they're embarking on a journey, and they know that I can be there for them and help them along the way. And that may include extreme ups and downs of mood and fear and anxiety. And what I try to do is help them learn to manage that anxiety. And for some people it takes a number of years, and for some people it's less time. It depends.
You've also done some work with adoptions. Could you tell me a little bit about that?
Well, I became an adoptive parent almost 10 years ago, and I had worked at an adoption agency as a therapist before that, and it was through that work that I became convinced that traditional closed secretive adoptions were not really helpful to the adult that an adopted child would become. It just didn't make sense to me that somebody wouldn't have access to their medical history, and that I, as an adoptive parent, wouldn't be able to say to my child, yes, your biological parent really liked art, or your biological parent was great at playing football, or whatever it might be. So I decided that if I was going to become an adoptive parent, I wanted to do an open adoption. And I had heard a little bit about open adoptions in California, and yet they weren't happening here in Vermont, except with older children, but not with infants. So I was one of the first people in Vermont to adopt very openly. I was there when my kids were born, stayed overnight in the hospital, and just had really special and wonderful relationships with the birth families. And one of my daughter, the daughter who's 10, still has contact with her biological mother. And I think of that as a really special thing, not only for my daughter, but for myself, because we're dealing with reality. I know how her birth mother feels. I know what it's like for her, the sorrow that she's gone through, and she knows about my sorrow related to the infertility, and together we share the joy of knowing this wonderful person, our daughter. And I know that we all have room enough in our hearts to love, just to love this child and to be loved by her. And she's really clear about who's there for her every night to tuck her in and so on. And she just thinks of her biological mother as a distant relative that she sees once in a while when she wants to, and when it's okay. And I'm the one who's in charge of that. It's not like I'm a part-time mother or a foster parent or something like that. I know that I'm her mother, and I'm also perfectly happy to share this wonderful daughter with the blended extended family that we are. My 7-year-old daughter, I was also there for her birth, and her biological mother decided that she would like some space. So she's available, if we have questions or concerns, but she's not wanting to socialize until my younger daughter is older. So that's the arrangement that we have with her. And there was one time when this daughter developed a very, very serious blood disorder, and it looked like she was going to need a bone marrow transplant. And I can't tell you what it meant to me as a mother to know that all I had to do was pick up the phone and call a biological relative, rather than feeling like, rather than trying to hopefully persuade a judge to open a record that might not be willing to open, and days of delays through court procedures.
I really liked how you referred to your daughters and their biological mothers as our child. That's really inspiring. I'm wondering, though, if there's a difference between, the way in which the 7 is connected to her biological mother seems different from the way that the 10-year-old is connected to her biological mother. And, it's like sometimes when kids have maybe different fathers, one feels neglected when they don't have the same contact. And I was wondering if the 7-year-old is feeling any kind of neglect or...
That's a good question, and we talk about that as a family, and talk about how it's really important for us to honor the things that are different about each of us, because we're not going to be the same, and we're all going to have different experiences, and that's just the way we are. And as it turns out, the younger daughter has a really, really actively involved godmother in her life. So that kind of fills that emotional energy that is experienced as this person who's not there every day like mother, but there's this person at a distance who's not a blood relative, but it's really wonderful for her and very loving with her and really cares about her. So she seems to think that, she seems fine with it. And that doesn't mean she doesn't ask about her biological relatives. But she accepts that those differences exist within families and between families.
And you are still working with adoptions, is that true?
Yes, I see some people in my practice who have adoption-related issues, whether it's a pregnant woman who's considering adoption and wants to talk about that, or people who have loss and grieving issues related to adoption, or adults who have been adopted. And I've also just had a book accepted for publication on attachment and bonding in the early years of adoption. So I'm working on revising that manuscript, and that's a book that's specific for adoptive parents. And the reason I researched that and wrote it was because when I was about to adopt, I found, and this is really true, Brenda, I found more books on how to adopt with a new puppy. I mean, how to attach and bond with a newly adopted puppy than I did on human beings. There was nothing out there, no books on how to attach and bond with a human being. And this is very difficult for foster parents too, because kids who have lost their biological roots, even if it's an infant, have different issues. So adoptive families are different. Doesn't mean they're less good or better. I don't mean that. But what I do mean is that there are differences. And the more educated parents are about that, the more likely they are to be able to deal with it and help the child to grow.
Well, that's really exciting. We've got a book that's going to come out. That's I certainly want to read that. And if we're still on, maybe we can invite you back to talk more specifically about what is in the book. If there are issues that you, the viewer, have become aware of and you'd like to discuss with myself or Margaret, call us and we'd be glad to talk to you more about any of these issues. Margaret's telephone number is 388-0248, and my telephone number is 388-0362. I also want to invite you, if you are a health professional or you know of someone who provides information or services around the health issues, to get in touch with me at that same number, 388-0362, and possibly we could have them on the program. Again, I want to thank Margaret for coming on the show and being our first guest and being so open about what she's doing in her private practice and sharing her personal experiences with us. Thank you, Margaret.
Thank you.
Hi, this is Healthfully Speaking, and I'm your host, Dr. Brenda Andrew, a psychologist in the Middlebury area. Today, I am very pleased to have Jennifer Barker, a mediator, and that's just one of the many hats she wears. Hi, Jennifer.
Hi, nice to be here, Brenda.
Now, you're a mediator.
I am a mediator. I have a private practice as a divorce and family mediator in Addison County, and I coordinate the Addison County Family Court Mediation Project.
What is that?
Which the mediation project was set up about a year and a half ago as an alternative for people who are getting divorced to work out a divorce agreement without fighting. It's an opportunity for them to sit down face to face.
But people who are divorcing always fight.
Yes, but it's possible to fight fairly. It's possible to have peace among enemies. And that's particularly true if a couple has children. Mediation gives them an opportunity to talk about the children's needs and what kind of future they'd like to create on behalf of the children, if not on behalf of themselves.
Can you really get them around considering their own revenge and spitefulness to think about the children? Because, I look at a lot of soaps, and what you see are people using kids, to spite the other person.
There are different stages that we all go through getting divorced.
Okay.
And the early stages are the most difficult ones because that's when all the anger is present. But it is a process, and some of that anger does begin to settle down. And particularly when people have an opportunity to really talk about what they need to say. Mediation isn't about going back into past history and digging it all up again. Mediation is a process for looking at the present, saying this is the situation, this is what is happening now, and this is how I want the future to look that might be quite different from the past.
So in mediation, are you mainly getting into kind of like property settlements rather than dealing with ways of saying goodbye?
Well, property settlement is certainly part of it. But what I have found is that sorting out property, at least in this county where many people don't have a great deal of property, is really not what's complicated. What's complicated is separating each parent's emotional investment in the relationship, separating that out from the kind of future parenting that they each want to have with their children.
Oh, that's interesting. So you help them to see how they can emotionally exist and physically function for the needs of the children and themselves?
And themselves, certainly. So often as a mediator, I'm asking parents what it is in their relationship with their children that they really want to maintain. Mm-hmm. And I ask a lot of questions about what the children are like, how old they are, what their interests are, what kinds of goals the parents have for their children, to begin to get them to look down the road. Because it's very easy in divorce when there is so much melodrama and so much emotion to stay just focused on right now or focused on the immediate past. But when parents begin to look ahead to their children's adolescence or young adulthood, then they begin to get the kind of perspective that helps them work out agreements that benefit their children. And that's why I do mediation.
What if there are no children?
Well, generally people who have no children, either because they never had them or because their children are grown, often if they don't have an attorney, they go through the divorce process entirely on their own.
So are you saying that there are not the kind of emotional or physical kinds of issues when they're not children and it's easier to separate?
I would say that 90% of the people I see have children. And sometimes they have children from several marriages. Sometimes one spouse has been a step-parent to one or two or more children for a good many years, in addition to that couple sharing children of their own. And then there are issues involving grandparents and how do these children get to maintain an ongoing relationship with all of the people who've been in their lives. So as a mediator, I have a chance in a pretty informal situation to ask a lot of questions, to help people focus on what's really important to them. And given that opportunity, many, not all, but many people would rather work out something that benefits their children than keep fighting. It's kind of the matter of, would you rather be right, or would you rather have peace? And as an old Vermont lawyer I have known said, if you want blood or money, you go to court and fight. But if you want to have peace and work out what is in human interest, then you sit down and mediate.
Now you said you represent the courts, or?
Well, I coordinate the project that is part of the Addison Family Court. There's several in family courts around the state. And we have a sliding fee service for people who are going through this court to get a divorce.
So would that mean that you would make referrals to other mediators, or do you just handle them all yourself?
I often make referrals to other mediators.
How many mediators do you know of in this area, in Addison County area?
Okay, in Addison County there are 3 or 4 of us. There are also quite a few mediators in Burlington.
How many do you think are in the state, since this program does go throughout
I would
the
say there are
state?
probably 60 or 80 mediators.
And how would someone get in touch with a mediator?
Well, if what they're looking for is someone to mediate a divorce, they could call their local family court. The other alternative is to call Woodbury College in Montpelier. They have a community dispute resolution center, and they also make referrals. And there's a Vermont Mediators Association, also in Montpelier.
Do you have the number of the Vermont mediators offhand?
Not with me.
Okay, so they could look that up.
I'm sorry, but again, they could call Woodbury College.
Okay,
and
get that number.
And get that information.
Great, great. How did you get involved in mediating?
Well, I was a family therapist for a long time, and was very frustrated by not being able to help families work on the specific kinds of conflicts that come up when a couple is approaching divorce, or even sometimes in a parent-child situation. As a mediator, I do parent-child mediation as well as divorce mediation. And I realized when I was planning to move back to Vermont after a long absence that I was ready for change personally. I was looking for something different, and mediation is a new challenge for me, and I enjoy it. I enjoy doing it.
So how did you actually get involved, though? Did you take additional training?
Yes,
or?
I took additional training at Woodbury. Vermont is very fortunate and unusual to have Woodbury College because it is one of the few mediation training programs in the country. And it's a very good program.
What is it? Is it a master's degree or is it a certificate program?
Woodbury offers a certificate.
Okay.
When you complete their program.
What are their requirements for admission into that program?
Well, you know, I don't really know what they are for everyone because I already had a master's degree in counseling.
Okay.
So I had a solid background, which made the process a little simpler for me. But again, that's easy to find out if anybody was interested to call Woodbury and ask those
Is there a
questions.
certification or licensure for mediators in the state of Vermont?
There isn't licensure or certification anywhere in the country, so far as I know. The Vermont Mediators Association has been doing quite a lot of work to establish standards of practice. And the family court mediation projects adhere to those standards. And they require both specific hours of training and hours of practice and supervision from a senior mediator.
Oh, that's very interesting. But since you wear many hats, I'd like to talk about some of the other hats that you wear. Why don't you tell us something else that you're involved in?
Well, one of the most challenging projects that I'm involved in these days is right here at MCTV. My daughter and I were watching a talk show program last spring, and as they often are, they were talking about kids. And she said, you know, Mom, they're always talking about kids, but you never see any kids on these programs.
How old is your daughter?
She's 11.
Okay, she's a kid.
Yeah.
Great.
So I said, you know, you're right. We should start our own television program. We should have a talk show for girls. And out of that conversation, quite rapidly, Girl Speak emerged. And Girl Speak is perhaps the only television program that is produced by and about girls and girls' interests.
Okay, what have you actually aired the program?
We have taped a program that we're editing.
Okay.
And we have several others that we're planning this winter. It's taken us a certain amount of time for us all to learn how to use the cameras and learn how to use the editing equipment and feel comfortable with the medium. Part of the premise of the program is that all the girls do everything.
Okay.
So that we don't have a star. They all learn how to operate the cameras and operate the computers in the back room.
How many girls are doing this?
Well, it's been ebbing and flowing. We've had as many as 20 and as few as 5.
How old are the girls?
They're all 11 and 12.
Okay, great age.
And it's a great age because you never know what you're going to get with an 11 and 12-year-olds. They have passionate views about the environment and relationship between boys and girls and what their rights are in school and how people ought to dress. And then they can be very silly. And it's a challenging age, and I really have fun with them.
So now you are putting together a program that lasts for how long? The one that you've been editing, is that a half an hour?
Their programs will be about a half hour finished. It's hard to tell right now because in addition to having a guest come on, or more than one guest, the first program is called Growing Up Female. And the guests included Catherine Nichols, who is the rector at St. Stephen's Church.
So this is an adult they're interviewing?
This was an adult they were interviewing.
Okay.
And a student at Middlebury College.
Okay.
And they were asking questions about, what was it like when you were our age, and how have things changed? And so we got quite an age spread, because we had two 11-year-olds and Catherine, and who is our age at least. She's not 11 anymore.
Just 21.
And Christina, who's 20 or 21. So it was a very lively discussion. So the programs have that kind of central format, but the girls are also producing their own creative material, which they call skittigates.
What's that?
And skittigates is basically anything they want to do. It can be as short as 30 seconds, they could be 3 minutes, they could be 5 minutes, they could be made up commercials. Two of the girls were taping a commercial about sharpening pencils the other day. They can make political statements, they can read their poetry, sing. They can basically do anything they want. And the point of it is to give them some flexibility in the process, but it also means then editing those short pieces into the larger program. So we're finding that actually getting something finished is
Difficult.
a little bit more of a challenge than we had thought.
But it's a good learning project for them.
It's a good learning project. And the program's called Girls Speak because in a lot of studies, particularly the recent AAUW studies about the development of young women, there's a kind of cultural brick wall that a lot of girls run into in junior high school. Girls lose their voices very easily.
Yes.
Girls who've been excited about sports and about themselves and playing with computers and loving math and science suddenly become very constrained.
Yes.
And they fuss about their appearance and they don't want to be different. And we call the program Girls Speak because it's very important for girls to keep their voices.
Yes. I can see this program now airing all throughout Vermont, and especially also in the classrooms in the middle schools and the grade schools. This is going to be a big hit. Oh, I can see it nationally now.
Yes, well, so can they. So can they. Yeah.
Right after Healthfully Speaking.
Well, they've got a lot of different subjects they want to work on. One of their plans is to construct a young children's a toy, a large wooden toy that needs to be designed and built with tools and big pieces of wood. We don't know what it's going to look like yet, but they want to build that this winter in a basement, and then they want to give it to one of the children's programs in the community. And they want to tape the construction of it, and then they want to have an interview with an architect, a woman architect, and then tape the giving of the toy and the young children playing on it. They also want to take cameras out on the street and go to the high schools and ask very personal questions.
This might be something that, if you haven't seen the Jennifer's program, by the time you see my program, you might want to call MCTV and request that program be sent to you, your TV station, or to your school. So I think that would be a very good idea. Jennifer, you've got some other things here, and this is a video. Could you tell me about that one?
Well,
could you hold it up so it can be seen?
This is Sharing the Circle. One of my lifelong interests is in mythology and folk tales, fairy tales. I was one of those fortunate children that got read aloud to a lot as a child. And Sharing the Circle is the first of 3 programs of traditional folk tales for children.
Now, are you talking on that?
I'm not talking on this. I produced this. The storyteller who's talking on this is a a professional storyteller
Okay, but you
who
produced
does a lot of
it.
performance storytelling. Yes, I produced it.
Now, how did you go about producing that?
Well, I had a good idea, and I set out to find out how to make it happen. And I happened very fortuitously to meet a man who has experience in film production.
Mm-hmm.
And we got into a conversation about what's on television for children,
Mm-hmm.
and our mutual concern for the lack of traditional stories available for children, because folktales are very important for children.
Mm-hmm.
Children tend to listen to the same folktales over and over again,
Mm-hmm.
and the characters in the folktale give children clues about how to live in life. And when children grow up without that, they're kind of left like as though they were in a boat without a rudder. So Andrew Silver was a big help for me in producing this. He helped me connect with a television studio in Boston, and
Uh-huh.
I found the storytellers and
Mm-hmm.
developed the idea.
So who wrote the stories?
The stories are traditional.
Oh, okay.
Anansi in the story box is a West African story.
Uh-huh.
The Chinese Stonecutter is a Chinese story, and Molly O'Donoghue, which is the other one on this one, is an Irish folktale.
So an international
Yes.
little video
Yes.
about stories. How nice.
Folktales are both have the essence of the culture that they grew out of, but there is in story tales and fairy tales a universal quality. Children anywhere in the world can listen to somebody else's folktale and recognize themselves.
So
in it.
if somebody wanted to buy that, could they contact you?
They could contact me. That would be the
Okay, and
simplest.
we'll give your name and telephone number before the end. And speaking of folk tales, this is...
Aha. Should I hold that up? This is The Goddess Within.
Now, what about that book?
Okay, well, do we have another hour here? The Goddess Within is, well, the subtitle is A Guide to the Eternal Myths That Shape Women's Lives. And in this, I and my co-author, Roger Wolger, explored the stories of 6 of the most famous of the Greek goddesses. And we were looking at them in this from the point of view of the different spheres of authority that those goddesses have within the Greek culture, and because we inherit in this culture so much from the Greeks in our own consciousness. Myths are like mirrors that we can look at ourselves in, and a goddess is ourselves writ very large, so that we can get a sense of ourselves in a much larger kind of context. In The Goddess Within, we explore the myth of Demeter, who's the mother. Demeter is the goddess of the grain and the ripe earth. She's also the mother of the maiden, Persephone, who's stolen away from her. Persephone is abducted into the underworld, and when she disappears from life, she's a child. She spends a period of time in the underworld, and then mysteriously she reemerges as a queen. Something's happened. She's changed. And she reflects to us the part of ourselves that dies and is reborn, is constantly transforming.
My daughter would love this book. She used to read these kinds of Greek mythology tales all the time.
Well, they live in us. These are archetypes, and they're recognizable. Others that we talk about in here are Artemis, who's the goddess of the hunt. She's a virgin goddess, which for the Greeks meant she was not married. Psychologically, that makes her very independent. Artemis is a very prominent goddess in Vermont. She avoids putting on pantyhose and getting all dressed up and being in city places and social situations as much as she can. She'd rather be out splitting wood or feeding her goats or cross-country skiing. Then there's Athena. Now, Athena is very obvious, probably at Middlebury College. You know Athena. Athena is the warrior goddess, but she's also the goddess of the city-state. She's a professional. She's an intellectual often, a student. She writes books. Then there's Hera. And Hera is a very interesting goddess because she and Persephone, between them, describe feminine power. Persephone is the deep inner power of internal transformation, but Hera is about worldly power. For the Greeks, her power was derived through her marriage to Zeus. But in the much older tradition, Hera was the priestess queen, and her power, her true power, was co-opted with the emergence of the patriarchy. So when we read about Hera, we experience her as being very angry, very bitter, because her marriage has taken something away from her. We often experience her in the modern world as being the president's wife. First lady, present first lady accepted. She's an interesting new wrinkle on the whole scheme of things, but Nancy Reagan was very much a Hera woman. And one of the things that we say in this is that all of these goddesses exist in all of us as women, and in less obvious ways in men as well. And different experiences in our lives, different times in our lives, bring one goddess forward and another one might recede. When we're in college, Athena is often a very prominent goddess. And then you're working along on a graduate degree or in your career, and all of a sudden you fall in love, and there's Aphrodite, the goddess of physical love and of beauty. And Aphrodite's not particularly concerned at all with matters of intellect. But perhaps when a woman gets married, Aphrodite begins to recede and Demeter begins to emerge. So there's an ebb and a flow with the goddess. And one of the points that I make is that it's a challenge for all of us as women to bring all of them to consciousness, to understand how they operate in our lives,
Yes.
how they influence us, and to allow them to have a dialogue, to mediate, going back to the mediation, to permit that kind of dialogue amongst themselves so that they each have a voice in our lives, so they each are allowed to contribute.
So we have our own Joseph Campbell right here in Middlebury, in the voice and form of Jennifer. That's wonderful. So someone wanting to know more about all the different skills, and I'm sure there's more that you haven't shared with us. You're just wonderful. How can they get in touch with you? Can you give us a telephone number?
Well, they can call me at at the Middlebury Mediation Center,
Okay.
and that number is 388-3212.
Do you also do storytelling yourself?
I have, but I like to listen to storytellers because, you see, I think being a true storyteller is a calling.
Uh-huh.
And while I appreciate it and I like to tell stories, it hasn't had that focus in my life.
Well, I was thoroughly captivated by your stories just now. Well, anyway, thank you, Jennifer, for coming
Thank you.
on Healthfully Speaking, and thank you again for tuning in, and we'll see you next time.
Hello and welcome to Health Matters, a show produced by Porter Medical Center on health, medicine, and long-term care issues here in Addison County. Our guests today are Dr. Maya Zimmerman and Kim DeGray. Dr. Zimmerman's a family practice physician in Virginia, and Kim is here representing the new breast health resource service at Porter Hospital. So welcome, both of you.
Thank you.
Before we begin today, talking about the breast health resource service and breast disease, why don't we let each of you spend a couple minutes introducing yourselves to our audience and talk a little bit about your work in the healthcare field generally and how you came to Porter and all that.
Well, I'm a family doctor. As you said, I've practiced in Virginia since 1981. As a woman physician, I have a practice that's fairly oriented towards women's health, and so I have a particular interest in this issue. And also as a family physician, I'm sort of in the front line in terms of first contact for women who have breast problems.
And you're also the president of the Porter Hospital
I'm the
Medical
president
Staff.
of the medical staff as of last spring.
And the first woman president of the medical staff, which I think is something you don't mind having said.
No.
Kim, can you tell us a little bit about your background professionally and how you came to Porter and where you are today?
Well, I've been at Porter for 17 years. I worked in the medical surgical unit and obstetrics and in critical care in the intensive care unit and most recently in the post-anesthesia care unit. And I'm now working with outpatient treatment services.
Okay, great. Well, our topic today is the Breast Health Resource Service, which is a new program at Porter Hospital to serve women that are diagnosed with breast disease. Before we talk about the service here in Addison County, Maya, can you give us some sort of perspective on how big a problem breast disease is in
Yes,
this country?
Ron. I brought some numbers so that I could be pretty accurate and up to date. The estimates are that in the United States in 1997 there are going to be over 182,000 new cases of breast cancer diagnosed, and it's about 1/3 of 30% of all new cancers that are diagnosed in women are breast cancer. It's also a significant cause of death in women. It's cancer as a whole is the #1 cause of death for women between 35 and 74. And breast cancer is the leading cause of death in the younger women in that age group, the ones up to 55. So it's a very major problem. And the statistics in Vermont I don't have details about, but we've had the estimates for 95, which I have the last year, was that there were 390 new diagnoses of breast cancer and 110 deaths due to breast cancer that year.
Wow.
That's a lot.
In Vermont.
In Vermont. So that's a lot.
Yep. And we read a lot in publications by the Vermont Department of Health and the local newspaper that Vermont ranks very high in the nation in terms of breast disease in women from a statistical perspective. Do we have any idea why we're so fortunate in Vermont to have that ranking up?
We don't really know. There are a number of things. One factor is that it may not be a true higher incidence, but we may be better at reporting. We're a small state and we have good statistics and information gathering. We may also be better at making a diagnosis, and if you have an increase in diagnostic accuracy of early breast cancer, you'll see a blip in the incidence. If you look at the statistics back in the nationwide, back in the 70s when Betty Ford got breast cancer, and there was an actual increase in the amount of women going in for diagnostic testing, there was a corresponding increase in breast cancer detected, and therefore a higher incidence. The same thing happened in about 80 when the American Cancer Society first came out with screening recommendations. A large number of additional cancers were diagnosed. So something like that might be happening in Vermont.
So it may not be that all of a sudden there's a greater prevalence of the disease. It's just that we're working harder to detect it.
Right.
And doing more so.
The other thing that Kim brought up that I hadn't thought about is that the national statistics are, of course, based on a different racial blend, and breast cancer is more common in white Caucasian women than in black women. So we may, as a very Caucasian state, see the benefit of that higher incidence.
Okay, that makes sense as well. And what about risk factors? Again, talking in a broad sense about breast disease before we get into the program at Porter. What are the risk factors for women who develop breast disease? Is it all family history? Is there diet? Is it stress? Combination?
The biggest major risk factor is age. If you look at the incidence of breast cancer as a function of age, if you're under 40, the incidence is about 0.5%. 40 to 60, it goes up to almost 4%. 60 to 80, it goes up to 7%, and it keeps rising over time. So the biggest risk factor, none of us can avoid. We all get older.
Right.
And that's a major factor that I think every woman should realize, because I see a lot of women say, it's not going to happen to me.
Right.
I don't have a mother or sister with breast cancer. That is a risk. The other risks are if you've had breast cancer diagnosed previously, if your mother or sister has had breast cancer, if you have certain changes on your mammogram, such as calcifications, or if you've had a diagnosis of atypical cells on a previous biopsy. Those are higher risk categories that we can definitely define. Women who've had multiple biopsies, even if the results are benign, are in a slightly higher risk. The information about diet is not good yet.
Okay.
There's a lot of speculation, and there is some interesting studies that show that high-fat diets are related to a higher risk of breast cancer. There's a lot of interesting speculation about pesticides and pollution, because some of those act like hormones, and that they might have a relationship.
And I think I either read or heard something recently that there was some study going on about women who had nursed versus women, I don't know if you may not be familiar with that study, but women who had actually had children and had nursed, that there was some sort of statistical correlation to that being reducing the incidence.
Well, especially if it's multiple pregnancies and nursing, because one of the other risks is women who do not have children have a higher risk of breast cancer. Women who put off childbearing till their later years and may only have one or two have a higher risk than what used to be common in Vermont 30 years ago, a woman who'd have 8 or 9 kids and nurse them all.
Right.
That probably has to do with the hormonal environment in the woman who's nursing or pregnant.
Right. Wow. Well, Kim, you're the nurse manager for this new program that we're talking about today, the Breast Health Resource Service at Porter Hospital. I think that we are officially launching it the summer of '97, and I think you actually have some women who are starting to be involved. Can you tell us, from a real overview perspective, what is this new service and what is your role?
Well, basically what we've done with the Breast Health Resource Service is taking services that we've already providing in Addison County and at Porter, and combine them with the services that we need to make breast health services comprehensive. So what we already have in place is very good primary care. We have a great radiology department with state-of-the-art mammography and high-definition ultrasound, and excellent surgical management. And the things that we've added to make the program more comprehensive is oncology services, an educational component. We've initiated a support group for women with breast cancer. We've firmed up the way that we make referrals for radiology therapy in Burlington, and we've added psychological support for women that need it. My role is to help coordinate patient care and to be a support person for education and support.
So how would this work in the real world? A woman feels as if she has, feels a lump. And does she call you? Does she call her primary care physician? what's the protocol? How does the ball get rolling in terms of, or what are her options?
Well, we would always encourage a woman to call her primary physician.
Mm-hmm.
That's the best place for her to start. Her physician can, initiate her into the system by calling the breast health service or radiology directly, whichever he or she prefers. Or if a woman doesn't have a physician, she can call directly, and we'll work her into our system.
Mm-hmm. So it's important that we try to tie every woman into some sort of primary care physician, so that there's that piece of the overall patient care spectrum. You talked about educational pieces. I understand that you're looking at some obviously brochures and pamphlets and videos, but also something maybe with the internet and tying women into some cyberspace educational components. What's that all about? What's there?
Well, we are actually building a lending library of materials, like you mentioned, books, videos, things that people can take home and look at their leisure. We also have a computer set up with an interactive program that women or their families can come in and use, and we're hoping to soon add a second program to that. We also keep a current list of internet sites that women and their families can use at home, or they can come in and access the internet off our computer.
Well, that's really exciting. Mm-hmm. So Maya, we touched upon the fact a moment ago that this new program will involve pulling together a lot of specialists and a lot of resources in terms of technology and education. But again, the family physician is really at the core of, I think, the patient care coordinating and making sure that the primary care piece is very important. How exactly, if one of your patients gets into the tract of the Breast Health Resource Service, how will you stay involved? What will your role be in this?
Well, let me first sort of emphasize something that I think Kim alluded to, and that is that right now we have a system where women can be entered into the system, get their diagnosis in a speedy and efficient and coordinated manner. Mm-hmm. And I think that we're adding another piece that sort of puts it together with the educational and the support and the sort of helping women. Some women want a lot of information, other women don't want as much. But I'm sure we'll talk later about treatment. And a well-informed patient is a much better has a much better prognosis and really has a better handle on things. And we've been fortunate at Porter because we have a fairly small medical community with fairly good relationships, so that we can triage and treat patients promptly. If a woman calls my office who has a lump, she gets seen rapidly. I can call and set up her mammogram or needle aspirate or whatever rapidly with radiology. They do their diagnostic work right at the time of a mammogram to some extent. We can call a surgeon and get an appointment within days. So diagnosis happens fast, and I think we want to be sure that we preserve that as we move forward and sort of organize ourselves a little bit more formally. Certainly, after the diagnosis is made, there's a lot of psychological issues and emotional issues for most women, as well as a lot of treatment decisions to be made. You have to know the pathology of the tumor, but once you do, you have some choices, and that's where I think the relationship of the primary care physician to the patient, which is a long-term one, can help her sort through some of the information that she has to decide about. And we do have a tumor board at Porter that meets monthly that discusses cancer cases with pathology, oncology, radiology. Primary care physicians are involved in that as well, so that a discussion about the best treatment plan for every individual woman is a team affair.
So you actually review charts of
We actually review cases. With some confidentiality.
Right.
I mean, there's initials used and so on,
Right.
so they're not identified.
But a lot of very intelligent people bring their resources
absolutely
to the table.
to the table and work on it together. And we have a tremendous pathology service and radiology service that can give the information to the oncologist and the surgeon and the family doctor to say, this is what we know about this particular woman's case, and this is where you should go.
So all the your point, I think, is well taken, that all the major pieces that we're offering to women have been in place for a while, but what we're adding is the educational support and Kim helping to kind of help the women navigate through what could be a multi-specialty. Specialty.
Right,
You know.
and I think that's very important, and
Right.
particularly in managed care, patients need to sort of know how things are supposed to work so that they, are referred in a timely fashion, but that their primary care physician is informed and involved as well. I think that's going to be very important.
What resources in terms of support do you have at your disposal, or are you lining up in terms of counseling or emotional support beyond the medical? What kinds of, are we working with the counseling service? Do we have people in-house? Is it your job? How do we do that?
What we do is we have an in-house person who sort of screens and directs people as they need, for what they need. Some people actually, the education and the support group is enough. Mostly what people need is to be educated, then they're not as afraid. But for people who need a little bit more, we do have a system in place for referrals, for psychological support. The support group is co-sponsored by Porter Hospital and Addison County Home Health, and that's been an excellent resource for women for emotional support as well as education, and that's a fairly new development as well.
And how often do they meet?
We meet the first and third Mondays of each month, and for an hour and a half.
So a woman who may be out there watching who is already in the midst of dealing with cancer, or who has a family member or a loved one who's dealing with cancer, they may want to just get into the support group. And so who do they call to get into to talk about the support group?
They can call the hospital or Addison County Home Health for more information, but anyone is welcome just to drop in. It's just an open group. There's no registration. It's totally free.
And all kinds of cancer, right?
Every kind of cancer.
So again,
right.
I think it's important that if someone is dealing with something that may not relate to our topic today, but it's cancer, that they should know that they can look into this resource that's related, but also somewhat tangential in terms of other.
Absolutely, and we also encourage family and support members to come also, even if the person with a diagnosis doesn't want to come. That can be very helpful as well.
In terms of them offering support. Maya, once breast cancer is detected and confirmed in a woman, you mentioned a minute ago that there are choices to be made. Now, obviously, if there's a certain type of disease or it's advanced to a certain degree, the choices may be limited. But assuming that there are, that it's at a stage where there are choices, can you describe the range?
Well, the range is tremendous, and what's interesting is that the range has changed so much in 10 years. In thinking about this presentation today, I looked back at a publication that reviewed surgery for breast cancer, and that was published in 1987, 10 years ago today, and it spent 2/3 or more of the text on modified radical mastectomy and radical mastectomy, which even then it said was not necessary, and a very small amount of time on what we call breast conserving treatment, which is totally the opposite. Now I think partly because we're diagnosing cancers early, we have the opportunity to do breast conservation. In other words, not to remove the entire breast and chest wall, which was done, a part of the chest muscles, which was done previously as a fairly routine thing. So that surgical techniques, which can be called a lumpectomy or a wide lumpectomy to remove the cancer or the quadrant of the breast where there is cancer is much more of an option for many women diagnosed with smaller breast cancers, earlier stage breast cancers. We also have a lot more information about treatment in terms of chemotherapy and hormonal therapy, so that it really depends on the woman's diagnosis, how big the cancer is, whether there's involvement in lymph nodes, how old she is, whether she's pre or postmenopausal, which makes a big difference in terms of treatment. And these are factors that each woman's case is going to be different, and what can be offered to her and what is the best choice for treatment, whether radiation, preoperatively, whether surgery, small surgery, large surgery, postoperative radiation, chemotherapy. These are tremendous number of choices, and most people haven't had to think about or analyze this kind of information before. So it's complicated.
It's
complicated.
New, and it's about their body.
And it's about their body.
It's at a time when they're probably psychologically not as well prepared to think about things of this nature.
That's why I think the kind of resources that Kim is offering are critically important, because you know, you have to learn to think in a different way. What is most important to me as a patient, you know? What kind of risk am I willing to take? What kind of side effects of drugs am I willing to tolerate? You know, and every person has to make their own decisions with the best advice that they can get.
Now maybe both of you would like to weigh in with your opinion about this, because obviously there doesn't seem to be an answer in this country with regard to when a woman should get a mammogram, and how frequently they should get one. It seems as if every few months the National Cancer Institute or the American Cancer Society or the federal government is saying, whoops, we changed our mind again. Sometimes some groups say that age 50 is the time to start, and other groups say, no, be safe, be cautious, start at the age of 40. And so there doesn't seem to be a real answer to this. So what's your opinion?
My opinion is also in a state of flux to some extent. I used to follow recommendations that said a baseline mammogram at 35, and then every 1 to 2 years after 40, and every year after 50. The problem with getting a good answer is that the studies are not yet there that show a decrease in mortality for women between 40 and 50 with regular screening. There's some technical problems. I don't want to be too technical, but mammogram is quite difficult in premenopausal women. The breasts are denser, so that they're more likely to be false positive results, abnormal looking mammograms that are not abnormal, no disease there, but they look suspicious. So they're less sensitive in terms of finding cancer, and they're more false positives. So that throws a sort of a monkey wrench, if you will, into actually proving that mammograms can save lives if they're done in that age group. On the other hand, we do also know that breast cancer between 40 and 50 tends to be more rapidly growing. So screening a woman every 2 years makes less sense in that age group than it might make in a 60-year-old who, if they develop cancer as they get older, women in their 70s and 80s, those breast cancers tend to be fairly slow growing and don't often lead to death. You know, it's a difficult thing to balance.
Right.
I try to discuss it with each woman to assess her risk, to offer her my best recommendation for her case. And I would say most of the time, patients between 40 and 50 that I see are screened every 1 to 2 years.
Do you have strong opinions either way on, or pretty much share Maya's view with regard to that?
Pretty much the same. I tended to go with the American Cancer Society recommendations at 40, and then every 1 to 2 years.
Okay. Every 1 to 2 years after that?
Until 50.
Okay.
And then every year.
Okay. We have a related topic to some extent is that we've introduced mammography services in Virgins, which is where you practice. Can you tell us a little bit about, either of you, about that and why it's being done up there, and what benefits there are to our patient population in terms of having an additional mammogram site in Addison County?
Well, I think it's a very big step to getting the numbers of women who are screened. This is a goal that the state has in terms of Healthy Vermonters 2000, is to increase our percentage of patients who have ever had a mammogram or who've had a mammogram within the last 2 years, which if we can offer more convenience, more sites to get it done, we should be able to increase our proportion of patients who are being screened. Right now, they're increasing, they're running about 40 to 50 mammograms per month at Virgins, which compares to maybe about 200 in Middlebury. The mammograms that are done there are purely screening mammograms. If a woman has a lump, is referred by her doctor for what's called a diagnostic mammogram. Those are done at Porter.
Right.
And I wanted to give you sort of an overview of what's happening in our radiology department, because they've made a big effort, which has really been fantastic, because I think so much of what's important to women is to mammogram is frightening. If you've never had one, or if you're afraid of cancer, it's a frightening experience. And to find out, have somebody call you up and say you've got an abnormal mammogram, you better go back and have another test, is very, very anxiety provoking. So what they're doing now is 80 to 90% of abnormal findings are followed up right then and there. The radiologist will get extra views that may clarify the issue and send them on their way with the normal result. They may do an ultrasound, which could lead to the same result. They may actually do a needle aspiration, which is sucking some tissue or fluid out of a lump that they feel needs further evaluation, so that the time to getting that report that everything is okay is as short as possible.
And I understand that service, that philosophy of trying to take the woman from the first procedure all the way through as far as is possible on that same day, in order to rule out or to detect and to basically come to some sort of determination, is fairly unique in Vermont. I think that a lot of other centers operate that you do have to come back and reschedule. And I think that that's something that I've heard talked about with regard to this breast health resource service, is that the whole philosophy of trying to do it conveniently and compassionately and same-day service whenever possible is really a main philosophy of this, which I think is, as Maya indicated, a very important distinction to make for this program. Kim, we've only got about a minute left. If women or anyone is interested in learning more about the Breast Health Resource Service at Porter Hospital, how do they get hold of you? How do they get more information?
Well, for an appointment, the woman's doctor can call and make an initial appointment, or if someone just wants information, they can call us at the hospital. The number is 388-8878, and come in and use the resources. Or if a woman doesn't have a doctor and would like to be introduced into the system, she can also call that number.
And if someone just wants to do the educational materials, is there a charge for that, or
No,
it's free?
not. Yep,
It's all
everything's
free.
Mm-hmm.
That's an important point to make as well. Great. Well, I think we're just about out of time, and I'd like to, it went by really quickly. It's an important topic, a lot of different things. Maybe we'll even do a follow-up show in a few months or a year after you have some experience with the service. But I want to thank you both for being with us this morning, taking time out of your busy schedules to join us. And I want to thank you for being with us today on Health Matters, and we'll see you next time on our show with Porter Medical Center. Thank you. Hello and welcome to Health Matters, a show about medicine, health, long-term care, and other issues in our community, sponsored by Porter Medical Center here in Middlebury. Our guest today is Dr. Bill Url, who is a member of our Porter Hospital medical staff and a urologist. Bill, before we begin with the questions, why don't you talk a little bit about your background in urology and medicine, how you came to Addison County, and just a little bit about yourself.
Sure. I graduated from Penn State University in 1962 with a BS in chemistry, and from the University of Pennsylvania School of Medicine in 1966 for an MD. Then I had a year of straight surgery internship and a year of general surgery residency at Penn, and that's where I decided to go into urology. They had no place the next year. They were filled up for a few years, so I ended up going in the Navy for 2.5 years as a flight surgeon and spent this extra 6 months as a fellow in urology. When I came back in '71, I began the final years of residency in urology at the hospital of the University of Pennsylvania and finished in '76, and I've been in private practice since. As to how we came here, Sue and I were looking for a physician in New England. I happened to find Porter's ad in one of our journals, made a phone call, spoke with Frank Bonacontro. We ended up coming out here, and to make a long story short, I decided to come here and moved in 1989, where I've been in practice in urology here since.
Okay, great. A flight surgeon in the Navy. Tell me about what's that about? How does that work?
Well, you see the big advantage of going in the Navy versus the Air Force, which also has flight surgeons, is the Navy will teach you to fly. And I got to solo a T-28, which is
not while you're doing surgery, though, right?
No,
that's good.
This is a 1,400 horsepower plane. It was a real thrill to fly it. We had a good time. They cost us, that's why it's 2.5 years instead of 2 years. But basically, it's taking care of a flight crew.
Okay.
I was on a helicopter carriers for about 3 months, and then on Okinawa and a little bit in Vietnam.
Wow. Wow, interesting experience. Our topic today is specifically prostate cancer. And can you give us just a general idea from maybe a statistical perspective, how big a problem is this? Is this something that really is a big issue for men in this country? How important is this topic?
Well, it surely is. It's both a common disease and a complex disorder. It's the most common cancer diagnosed among American males and the second most common cause of death among American males. The incidence of prostate cancer is increasing. It'll probably level off now, but I think because of the popularity in the print and video media and the people with big names who admit to having the disease, a lot more prostate cancer is diagnosed simply because men are going to see physicians, and also because of the availability of PSA screening. It's complex and somewhat controversial because of a number of factors. First of all, it's a disease of aging. It's estimated that 50 to 80% of men over the age of 80 will have prostate cancer. Probably we all will if we live long enough.
Wow.
And it doesn't mean that it's not a disease we don't have to worry about, but the older we are when we get it, the less of a problem it is. Knowing this, it's estimated that about 50% of men with prostate cancer never know they had it.
Wow.
And that's a second factor that confounds the screening and treatment of the disease. It's estimated that 8 million men alive today have prostate cancer, but 50% of them, 4 million, will die with the disease.
Not even knowing
They will never know they had it. And that presents a dilemma to us in that we wouldn't want to diagnose cancer in those patients because then we might feel obligated to treat it. And if we did, we'd certainly do more harm than good. All therapies contain certain complications. And these men never have a problem with the disease, so one wouldn't want to overdiagnose it, so to speak. And the third problem is it's a bimodal disease with regard to age. Cancer diagnosed in 50 and 60-year-old gentlemen is a much more serious disorder than that diagnosed at the age of 70 and older. What this means practically is that I'm sure you've heard of watchful waiting or observation as a method of treatment, which obviously it's not a therapy. It's an irrational course for a 50-year-old, whereas for someone 70 and older, it may well be something they could consider. So there are three factors that are important there. It's a disease of aging. We're all going to get it sooner or later.
Right.
It only kills half the people that have it, and the other don't even know they have it. It's not that they just don't die from it. They don't even suffer from it at all. And the third factor is you don't want to treat older patients who develop prostate cancer in general as aggressively as you would treat younger patients.
So it sounds like this particular form of cancer has a lot of, at least from a layperson's perspective, what seem to be unique attributes. You know, the older you are when you get it, the better news it is. You know, not treating it is a good way to approach it, and you know, and that you could very well live many years with it and not know that you even ever had it. Is one of the factors because it doesn't spread as rapidly? Is that part of the reason? I mean, you hear with you know, breast cancer or cervical cancer or other kinds of cancers, you know, next thing you know, it's in the lymph nodes. Next thing you know, it's in some other organ or some other systems. Is this such a slow spreading cancer that is that one of the reasons why?
Well, that's what makes it difficult. Some are and some aren't. It's the point I'm trying to make with the older patients. When they get it, we've known since the 70s, it's been in our literature, it's nothing new, that when you have a 70-year-old with a new diagnosis of prostate cancer, you can expect in general that the cancer will be more slow-growing, won't be as aggressive as it will be in younger patients.
Okay.
It won't tend to spread as fast. It doesn't mean you can ignore it.
Right.
It's not a benign disorder. If you don't watch him,
Right.
and he lives long enough, he will die of the disease unless treated. But it is, the cancer itself will progress more rapidly in some patients than others. It's a little complex to explain exactly why, but
Right.
basically age is a big factor in general.
Okay. That's so it actually can grow more slowly the older that you get.
That's right.
What about risk factors? You know, genetics and other areas. It sounds, I mean, based on what you said, all of us would get it if we lived long enough. So I guess there are some universal risk factors that are out there. But I mean, if a person has this in their family, should they be more concerned about it? Should they get screened earlier? Or is there some relationship to your diet? I mean, what can a person do to avoid it other than not changing their parents, which you can't do?
There isn't much you can do. You mentioned the most important factor is just aging, and we can't do much
Right.
about that. Probably the only epidemiologic study indicating a relationship of any kind of activity to the development of prostate cancer is a high intake of dietary fat. I don't know a urologist anywhere that's advising his patients to go on a low-fat diet to avoid prostate cancer.
Mm-hmm.
It's a loose association, and there are many better reasons not to eat a lot of fat
Right.
than to worry about whether or not you're going to get prostate cancer. But that's the only factor about which you might think about behavior being involved. Genetics is very important, and that's something new. When I was in residency, we weren't aware of that to the extent at least we are now. There are definitely families with a high incidence of prostate cancer. What this means practically is that men ought to be aware and ought to pursue in their own family a search as to whether or not prostate cancer is present. If prostate cancer is in a primary relative, and we define that as a father or a brother, it could be a mother or sister, but obviously they don't have prostate problems.
Right.
A father or a brother, your risk is increased by a factor of 2. If there are 2 primary relatives with prostate cancer, your risk is increased by a factor of 5, and with 3, 11. So it is an important consideration, and it's something that you ought to make yourself aware of and make your family physician aware of, and your urologist too. You ought to be able to tell them if there's a family history of prostate cancer. On the other hand, like anything else in medicine, you have to take that with a grain of salt. I just said it's a disease of aging.
Right.
If your father is 87, he was just diagnosed with prostate cancer,
Right.
and he and his urologist elected not to treat it, just observe it,
Right.
and he dies at 95 of heart disease. His prostate cancer was never treated, never caused a problem. That isn't what I'm talking about. The genetic form of prostate cancer tends to involve younger men under the age of 70, for the most part 50s and 60s, and that's what you're looking for. It doesn't mean that you should ignore the fact that prostate cancer is in your family and your father got it when he was 87 and never got in trouble with it. You should be aware of that and pass that on, because maybe that'll be important in the future too. But what we're really worried about are younger men who develop prostate cancer, meaning in the 50s, 60s, 70s.
Okay.
Not 70s so much, but 50s and 60s.
Okay. And in terms of genetics, they're doing, we read a lot in literature and watch and on television about genetic screening, and that they're trying to predetermine if a woman, for example, is going to get breast cancer based on a genetic. Do you read in the literature anything that's happening in those lines in terms of prostate cancer?
I don't know that that's ever really going to happen.
Yeah.
It's not particularly important in this disease, since there are various risk factors, one of which is aging, which we all share.
Right.
So sooner or later we can all get it.
Sure.
Genetically it's not going to be important in that regard, but just the family history, it's a gross relationship.
Okay.
It isn't, I don't think anybody's going to know what part of the chromosome is abnormal, and if that's abnormal,
Sure.
you're going to have trouble getting insured.
Okay. As a urologist, what is your recommendation to your patients in terms of age and other factors for when men should begin to be screened for prostate cancer, and how often they should be screened for prostate cancer?
Well, like most urologists, I agree with the recommendations of our professional organization. The screening ought to begin at the age of 50 and ought to consist of an annual PSA and digital rectal exam. If there's a family history of prostate cancer, as we just discussed, then screening ought to begin at the age of 40. And for Black Americans, it's recommended that screening begin at the age of 40 because prostate cancer is more prevalent among blacks than among Caucasians.
Okay.
There's some controversy over screening, as I'm sure you know. The American Cancer Society, until a month or two ago, agreed with the American Urologic Association on the timing for screening. They've changed their stance somewhat. They certainly aren't recommending against it, like the some of the family practice, I should say primary care organizations do. So we should be aware that there's some controversy about that. But again, as a urologist, and as our conversation progresses, I think you'll see there's a pretty logical reason for the screening.
Okay. And before we talk about the screening, as an individual patient who, let's say I'm 48 or I'm 49 years old, not quite ready for my first screening, but are there symptoms? I mean, is there something that a man could detect as some sort of symptom that might cause him to say, well, I'm not quite 50 yet, but gee, maybe I better go and get this checked? Are there warning signs or anything that just a layperson could detect as early signs of prostate cancer, or is it really something that has to come through a test, a diagnostic test?
There are no signs. It's a silent disease in the beginning. By the time one experiences symptoms, it's generally too late to operate or treat for cure. That isn't always true. If you, some of the things I look for among my patients are a history of, over the past 3 to 6 months, for instance, an increase in day and night frequency that's persisted for 3 weeks, difficulty holding the urge, losing urine on the way to the bathroom when they didn't do that before, and again having it persist for that length of time. In other words, a sudden change in irritative symptoms can reflect the presence of a prostate cancer, and acute retention, inability to empty the bladder that occurs in a younger man, 50s and 60s, also can be an indication of prostate cancer, but both can reflect underlying benign disease. So it's nonspecific. The only way you can pick up a prostate cancer early is through screening and PSA testing and digital rectal exams. Okay,
well, let's talk about that. What exactly is the PSA screening, and what are some of the advantages of this test?
Well, the screening itself is, as we just described, it's a matter of getting the study done once a year beginning at the age of 50 or 40 as appropriate. But what is a PSA? PSA stands for prostate-specific antigen. It's actually an enzyme in the semen that has to do with liquefaction of semen after ejaculation. It doesn't belong in the bloodstream, and how it gets there and why we don't really know. But we are certain that for an identical volume of prostate tissue, cancers lead to 10 times as much PSA accumulating in the serum as benign disease. So that makes it useful in the diagnosis of prostate cancer, but not specific for prostate cancer. The problem comes, therefore, in determining what to do about a PSA that's above the lab normal. 10 years ago, when PSAs first came out, we biopsied everybody. And you end up biopsying 6 patients to find 1 cancer. So you've done, under those circumstances, 5 unnecessary biopsies. And that's unacceptable to us, and it's not pleasant for patients. As time has gone by, we developed other techniques or ways of using PSA. And the most common and most sensitive and specific method of determining when to proceed with a biopsy and to suspect the presence of a cancer is called PSA velocity, which relates the PSA level from one year to the next. If the PSA increases by 0.75 ng per dl, and you can forget the ng per dl part, that is suggestive of a prostate cancer. It doesn't mean it's present, but it may indicate the presence of a prostate cancer. And what you do is not panic at that point, but just get a PSA in 6 months. And if the increase is continuing, then you want to think strongly about proceeding to a biopsy. If it backs off or stabilizes, then that might be just a benign change in the prostate, and you don't have to worry about it at that point in time. You will want to check it again in 6 months to make sure it really is staying the same or getting better. Prostate cancer is so slow growing that if you have a patient who's reluctant to proceed with a biopsy after the first increase and then a verification 6 months, if you want to wait another 6 months, that's okay too, to be almost certain that the cancer is present. Under those circumstances, the positive biopsy rate is much higher than if you're looking at a PSA first study done slightly elevated, as we did in the past. Another way of determining how important a PSA change is to compare the serum level of PSA to the volume of the prostate. This is called PSA density. That concept is not particularly useful because you measure the prostate volume using ultrasound. It turns out that's pretty operator dependent to get the dimensions, and you're measuring fore and aft and side to side. And then you use an equation that assumes all prostates are the same size, which they aren't. So you can end up with some spurious values at close to there's a large gray zone, put it that way. Nevertheless, if you have the data, there's no harm in using it. And if you're trying to, you really don't know what to do, and you do the density and it looks quite high, then you might want to go ahead and proceed with a biopsy. And if it's extremely low, you might feel, this is benign, I'm not going to worry about it, and we can check it again in 6 months. But most people do not use density data anymore. You may have heard of free-bound PSAs. It's a new assay that will become available. Maybe it is in some places now. That was developed a number of years ago to eliminate the uncertainty in the gray zone as to whether or not to proceed with a biopsy. It would be a simple test. You'd take your PSA, first one you ever got at the age of 55 is in the gray zone. It's between 4 and 10. It's 7.5. And you don't know what to do. And you don't want to be a 1 out of 6 shot at getting a diagnosis of prostate cancer. So you do the free-bound assay, and that's supposed to tell you whether or not you need a biopsy. Well, we've been looking at that for about 1.5 years, 2 years in the literature strongly, and there still is no cutoff point between biopsy and no biopsy. Well, if it's taken this long to decide on the cutoff point, you can imagine it's going to be another gray zone study.
Right.
It's also going to be more expensive than a regular PSA. And finally, if you're using PSA velocity, you really don't need it. The only time I can see that that's going to be valid in the future is in the situation I just described, which will be hopefully less and less common as time goes by.
Okay.
One of the big concerns about PSAs is they're going to cost too much. Over the years, screening everybody. One of the ways to perhaps alleviate that is to establish a baseline over 2 to 3, 4 years, and then get PSAs every other year. Again, prostate cancer is so slow growing that it probably would allow. That's my idea. I think I do that with patients, but I think I'm sure other urologists have thought about it, and I suspect that that's something we'll do in the future.
So is the PSA test something you would just normally do at when a man presents himself for his initial screening at age 50? Is the PSA part of that?
Yes.
Okay. And then your recommendation is maybe a couple years later?
Well, no, I definitely get a baseline first. You want to do it at age 50, 51, 52, and
Okay.
if the numbers are all pretty much the same, and they'll range about 1 NG per DL then you can start moving it out to every other year. But you want to get a good solid baseline of data first. Some men aren't that kind. They'll have a 1 and then a 1.5 and a 2 and a 1.5 and a 1, and they'll sawtooth back and forth like that. But it doesn't matter. They'll just need a wider baseline so that until you become comfortable with the data.
Okay. If you are a young man and you're diagnosed with prostate cancer, obviously the first question that one would ask is this curable? And what are the treatment options, that are available to try to cure this disease? So is it curable, and what are the treatment options?
Well, sure it is. It's always been curable.
Right.
The thing that's changed over the years is the number of patients who present at the time of surgery who are curable. Before PSAs came along, we made the diagnosis by rectal exam and feeling the prostate and feeling a nodule or a lump in the prostate. When I started practicing in the 70s, a lot of primary care physicians didn't do rectal exams, which surprised the heck out of me. It wasn't a disease that was talked about very much, so often the disease presented late with metastatic, a metastatic situation and death not too far away. As time went by, more and more rectals were done, but still the way of picking up prostate cancer was with a finger exam in the prostate and noticing a nodule. Well, when those patients went to surgery, their odds of having cancer confined to the prostate, organ-confined cancer, were only about 30%. And for any cancer, that is a goal, to diagnose early enough to have the cancer confined to the structure from which it originates. So we're way behind the 8 ball, even then, waiting until there was a nodule present. The prostate already contained a fairly large cancer. Well, what happens with PSA testing is that we're moving way up in the curve of growth in the prostate cancer. There are many more men presenting now with organ-confined cancer, and these are we consider to be curable cancers. There is a dearth of data in the past with regard to organ-confined cancer because there just weren't many patients who were operated on that had it. And for many years, we just didn't do many radical prostatectomies. Now it's difficult to convince our primary care confreres that we've indeed changed things and made some progress, and that we ought to give the early testing and increased number of patients presenting with organ-confined prostate cancer a chance at surviving. In other words, if you don't do the screening, you won't see that.
Right.
So it is certainly a curable disease, much more so now than before, but in the numbers. If the same situation today transposed to 1930s, it was just as curable then. We're just seeing a lot more
You're catching it earlier.
That
catching
can
it
be
earlier.
cured
And that's why
this
the
time.
PSA test is important, and people should get their screenings at age 50.
That's right.
Is surgery the only treatment?
No, there are really only 2 forms of therapy, though, that I consider valid: surgery and radiotherapy, external beam radiotherapy. They've stood the test of time. There's a lot of data available. As a matter of fact, Contemporary Urology this month has a long, multi-page essay, dialogue between 2 urologists, or a urologist and a radiotherapist, as a matter of fact, over which is better. We still aren't sure yet. The other forms of therapy for prostate cancer that you might hear about, cryotherapy, for instance, is definitely experimental. I would not recommend that. Something called brachytherapy, which is radioactive seed implant, is becoming more and more popular and getting in the media. The president of Intel had that form of therapy, and that got in one of the popular business magazines, so that's given that treatment more of an edge than it had before. But a little story about that. The reason they call it brachytherapy now is because it was tried once before in the 70s, and it was called radioactive seed implant. And 20 years later, we know very well that that therapy was absolutely useless. It was as good as no therapy at all. And I cannot imagine how in 20 years we're going to go from a useless form of therapy to another kind of seed implant. And this seed implant is going to be much better than external beam radiotherapy. So in spite of good reports at 10 years, I think that's not a form of therapy that I would recommend. And I only mention those two forms of other therapies in passing to my patients when I'm discussing treatment for prostate cancer. Not as a recommendation.
So of the two therapies that you do recommend, you know, what attributes of the patient dictate which of the two courses you recommend, or is it totally up to the person if they want to go down the radiation route or if they want to just get the thing cut out? You know, how do you make that call?
Age is the primary criteria. Young men, surgery; older men, radiotherapy. But there's no reason why older men, to a certain degree, can't have surgery, and particularly younger men can't have radiotherapy. What I do is describe the pros and cons of each in detail, and I tell them what my recommendation is and why I would recommend that form of therapy for that particular situation. But I let patients decide. I don't usually have them, they aren't usually ready to decide in the office at that time, and I encourage them to go home and think about it.
Now, is radiotherapy like similar to chemotherapy, or is it just radiation?
Radiation is delivered directly to the prostate through the skin of the pelvis, and involves going to the radiotherapist 5 days a week for 6 to 8 weeks. It's a relatively painless, simple procedure to go through.
Side effects like chemo or?
No. Side effects are some diarrhea and some frequency 3 weeks into the course, which will continue maybe 2 or 3 weeks afterwards, but easily treated by the radiotherapist. And maybe some loss of energy, but that's basically it.
Not as devastating as...
Oh my goodness, no.
Right.
No. Radiotherapy, that's the problem, is that it's, as I'm presenting it, it sounds like an awful good alternative to surgery. It is for some people, but in others, surgery is much better. The reason is because the data, again, this is in the literature, and this will change with time. But it's all we have to look at right now. For 10 to 15 years, survivals are about the same for whether you've been treated with radiotherapy or surgery. But after, say, 12 to 15 years, the surgical patients definitely tend to be surviving longer free of disease, where the radiation patients are exhibiting more and more recurrence and death from prostate cancer.
So that should be part of your decision-making process, obviously, in terms of
Absolutely.
that data. Great. If you've given a tremendous amount of information, I can't imagine what more anyone could want in terms of information about prostate cancer. But if there's an aspect of this disease or this topic that a person wants more information about, how should they proceed? Who should they contact?
I kind of prefer that they contact their family doctor or their urologist. I think when you start going out of town for information, it's not that I object to that, but I think you have to make up your mind where you want to get treated, and you should be comfortable with that. If you want to go out of town, then you should go out of town and get information and act on that impulse. But there is no, I don't know anybody in town who isn't comfortable with the basics of treatment of prostate cancer and who wouldn't refer patients if they needed more information. So I think local physicians are probably the
Check
best
with your
way.
family doctor or in the phone book under Porter Urology, right?
That's right.
That's right. Bill, I think we're basically out of time. 30 minutes went by pretty quickly. You gave a lot of good information, and we appreciate you being our guest today, and thanks a lot.
You're most welcome.
All right. So thank you for joining us this week on Health Matters, and we'll look forward to seeing you next time. me do when I'm talking. Hello and welcome to Health Matters, a show produced by Porter Medical Center about health, medicine, long-term care, and other issues concerning our healthcare community in Addison County. Our guest today is Dr. Lorrlee Schoenbeck, a naturopathic physician who does work here in Middlebury, as well as your other offices in Shelburne, Vermont. So, and our topic today is naturopathic medicine, and we're going to talk a little bit about our health fair coming up in May, and you've been very involved in that, and a panel discussion that you've organized that I think will be really informative for not only our broader community, but maybe members of the professional community as well. So why don't we begin, Lorrlee, by letting you give a little background information about yourself, both personally and then maybe an overview of your work as a naturopathic physician.
Okay. This is always fun to do, Ron, because I come from a long family tradition of medical doctors. I'm the 4th generation physician in my family, but the first to practice natural medicine. And my training is in naturopathic medicine, which is in many ways very similar to conventional medicine and in some ways is different. The training is a 4-year naturopathic medical school curriculum, which follows basic pre-medicine courses, a bachelor's degree, and the same prerequisites as any conventional medical school. Mm-hmm. The first 2 years of the training involve basic medical science, so your anatomy, physiology, biochemistry, pathology, all of the ology courses are covered, and basic science board examinations are required after the first 2 years, which is the same as conventional medical training. In the 3rd and the 4th years of the training, the focus is on clinical education, but rather than rotating in hospital clinics, we do all of our clinical training in outpatient settings. So in large family practice teaching clinics overseen by staff physicians, and are trained as more of a general type practitioner who uses natural therapeutics rather than conventional therapeutics most of the time. Now, there's no opposition to conventional medicine from the naturopathic world whatsoever. We certainly acknowledge that there's a place for every type of medicine, and we refer to conventional physicians readily. What we do is cover a broad spectrum of general health care using natural and preventive types of therapies.
Okay. I'd like to talk more about your profession from a real philosophical perspective, sort of to give a real background and a basis for our talk. And then also, but to focus in on what you were talking about a minute ago, in terms of your training and your clinical rotations, are your rotations with other naturopathic physicians, or so when you're talking about clinics and large teaching, these are your peers?
They're peers run by
versus
right.
Okay.
Licensed staff, naturopathic physicians. Of course, there is the opportunity to do preceptorships with other professionals from other disciplines. And because of my family background, I took advantage of that opportunity and actually did some work in hospital with my father, worked in surgery, and also did many family practice rounds with colleagues of his. And in that way, I think had a very good introduction to conventional medicine practice in addition to the naturopathic training. That's my particular area of focus, is how to bridge the worlds between conventional medicine and natural medicine.
Okay. Well, let's start at the beginning in terms of our probably many members of the audience watching are clueless as to what you do and how you do it and how you are the same and how you are different than the traditional MD, medical doctor. So maybe start a little bit about, again, in terms of your background, 4th generation physician. How did you learn of naturopathic medicine? Why did you, decide this was something you wanted to do? And
Well, I, like most people, had never heard of naturopathic medicine, and I was always tracked to go into the conventional medical world. And that was where I thought I was going. And I was researching types of medical schools which...
So you knew you wanted to be a doctor ever since you were a kid, sort of
Age
thing.
2,
Right.
Ron, really.
Right.
I went on rounds with my father
Right.
every week on Sundays, and I remember telling his colleagues when I was probably 6 or 7 that I was going to be a brain surgeon.
A brain surgeon?
Yes. I wanted to one-up my father, I guess, at that age. He's a general surgeon. And so when I was in my pre-med training at the University of Wisconsin-Madison, a nursing student friend of mine told me about naturopathic medicine because she knew that at that time I, in my personal health care, had been exploring some alternatives such as massage therapy, osteopathic medicine, and chiropractic medicine for a back problem that I had at the time. When I was sent away for a catalog to the naturopathic medical school, I immediately recognized a curriculum that combined conventional medical science, which I felt was very important, with the therapies of nutrition, botanical medicine, homeopathy, physical manipulative medicine such as spinal manipulation, and lifestyle counseling. These types of therapies made sense to me, and I wanted to learn them in an educational setting which allowed for basic medical curriculum as well. So to me, when I looked at the curriculum, Ron, it felt like the best of both worlds. And I have to tell you, my decision was made immediately as to which path I would take, and I withdrew my applications to the conventional medical schools, much to my father's chagrin at the time.
Sure.
But we've since come around and had a meeting of the minds, so to speak, on that topic.
Great. So basically, this is a practice of medicine that, in your view, is more holistic and takes into consideration perhaps a lot of factors in terms of a person's lifestyle and nutrition and maybe frame of mind. I mean, all the other things that traditional medicine doesn't always focus very much on.
Absolutely.
Traditional medicine looks at the disease, the system, medicine to treat it. I mean, this is in your estimation, a broader view.
Right, and it's very important that the conventional medicine do focus on disease at a certain point when it gets to the point where you really need to focus on disease care.
Do you intervene earlier then? I mean, are your patients, do you have more well checks?
Yes, that's what we try to do. Of course, it's always a challenge to get patients to actually come in to see the doctor when they're not feeling sick.
Right.
But when a patient does come to me and say, Doc, I'm not here because I have a problem, I just want to learn how to stay well. That's one of the funnest types of visits I have. I'd like to talk a little bit about the philosophy of naturopathic medicine because that does clearly distinguish it and gives its place among the continuum of various disciplines. The core philosophy of naturopathic medicine is based on a principle that we call the vis medicatrix naturae. That's Latin for the healing force of nature. And we believe strongly that your body has an inherent healing ability. That means if you cut yourself, it's a small cut, you don't have to think about how your tissues are going to mend, how you're going to bring amino acids to the site, anti-inflammatory molecules, lay down collagen fibers, bring white blood cells to prevent infection. You don't have to think about that process. There's an inherent healing force in your body that knows exactly how to repair itself and bring you back into homeostasis in other cases. So we utilize that principle, and our philosophy is to support that underlying healing potential nutritionally, environmentally, and provide an environment in your body so that you can heal yourself whenever possible. If we can also help to remove impediments to that. If there's something that you're doing in your lifestyle that's damaging that ability to heal yourself, we try to identify that. So that's one of our core philosophies. Another philosophy is doctor as teacher. And in fact, the word doctor does mean teacher, docere in Latin. We take to heart that definition and inform our patients about their health care and how to stay well so that they can become empowered to be more participatory in their health care choices. A third philosophy is that we are made up of mind, body, and spirit. We are whole beings, and you are not just your pancreas or your gallbladder, but you are Ron, who has a variety of situations, stressors, nutritional status, genetic factors, health history that impact on your health. So we feel it's important to take a look at the whole person. And in doing so, we end up spending a lot more time with our patients than they're used to getting in a conventional setting.
So if I'm your patient and I'm seeing you as I should be seeing you, then I will check in with you occasionally with appointments at times when I am not sick, but we just want to check in to let you know how things are going with me, check in with my routine of exercise, diet, whatever. I mean, you teacher, as an advisor, as someone who advocates, the taking care of yourself and trying to avoid health problems, that's a role that you feel is right up your alley. That's a primary role.
In fact, if you came in to see me and you had a family history of heart disease, and we identified some dietary and exercise factors that were in need of adjustment in your lifestyle, we would put those into place now to prevent the heart attack that could occur 20 years from now. And an ounce of prevention is worth a pound of cure, as they always say, and we feel that in that way we'll be able to save healthcare dollars as well as make your life a much healthier life.
Sure. And as you've mentioned earlier, I mean, to be totally both sides of it or whatever, one of your interests is the interface between natural and traditional medicine, and I'm sure that there are a lot of especially primary care physicians out there who would say, well, I do that too. I mean,
Absolutely.
I think we need to make that point as well, that
Absolutely.
There are a number of family practice physicians and certainly pediatricians and others who really see as a primary focus of their medical practice seeing kids when they're healthy, well child checks, seeing adults during regular checkups and whatever. So a lot of what you do does also look similar.
Very much overlap. And in fact, the family practitioners who I'm most closely associated with and I have very identical philosophies. I think that they're very, very compatible.
So when do they turn a patient over? Does that happen? A traditional family practice MD has a patient who, for whatever set of reasons, this doctor feels like this patient could use some intervention from you. How does that happen, and why would that happen?
It's happening more and more frequently. In fact, I estimate that approximately 1/3 of my patients right now are coming as referrals from their medical doctor. And they usually are coming to their medical doctor with a question: do you know of some herbal medicine, some nutritional medicine, or a natural approach that I can take rather than going on my conventional blood pressure lowering medication, estrogen replacement therapy, whatever. It's coming mostly from the consumers or the patients, which are asking their medical doctors for a natural approach, but of course the medical doctor's not trained in the natural approach, and then refer to the naturopathic physician who is.
So there are physicians in our area who feel comfortable saying, I don't know the answer to your question, but here's the name of someone who would know, and actually refer, and about a third of your patients, that's...
About a third of my patients now. That's certainly an increasing number.
Are there educational programs for naturopathic physicians in Vermont, or do you have to go to a large city?
Yes, there's none in Vermont. It's there are 5 in North America right now. They're located in Seattle, Portland, Oregon, Scottsdale, Arizona, Brantford, Connecticut, and Toronto.
Okay. Many of those are larger areas where I assume, again, you need a core of colleagues to do your clinical, so it'd be difficult to have a program and where there was not a lot.
We dream of that, and at some day perhaps we'll be able to do something like that. We'd love to be affiliated with UVM, for example, and there are some chiropractic colleges, Bridgeport University in Connecticut has now added a naturopathic program. Some osteopathic colleges, I believe, are looking at the option to add a naturopathic program because the first 2 years of the curriculum is basically identical. Right. And having the additional 2 years of naturopathic training is something that many of, in fact, the professionals in the fields, the MDs and the DOs and the DCs, are looking into themselves. And there are several people with joint degrees, ND, DC degrees, chiropractic and naturopathic degrees, and that's starting to happen with some medical doctors and osteopathic physicians who were in my program while I was going to school in Portland, Oregon.
Now back to the interface between traditional and natural medicine, which is sort of our primary topic today. Let's talk about patients going in the other direction. Let's say I'm a patient of yours and you've been managing my care and I've been healthy and everything's great, but you pick up on a problem, you know, a disease state in me that you feel is beyond what you've been trained for. How does that work? What is your...
Exactly the same way that any family practitioner would refer to a specialist. So say that you came to me with a blood pressure problem and we weren't able to control it with dietary, exercise, and herbal measures to a degree that we felt was safe. I would refer you to one of the 3 or 4 cardiologists who I refer to on a regular basis.
And those physicians accept the referral and communicate back to you.
Yes.
In terms of what they're doing with your patient, and so you have a good collegial rapport.
Right. So I'll send your chart notes up with for your first visit with that person. They will be a consulting physician. They'll send me a report back of their findings and send the patient back to see me.
So I guess the bottom line is, if I choose you as my primary caregiver, I'm not abandoning traditional medicine or the ability to get back into that system if need be, and vice versa. That if I am not quite ready to have a naturopathic physician as my primary caregiver, but want to leave that option open as, you know, to sort of augment my care, that if I go to a traditional doctor, you're not going to slam the door in my face either and say, sorry, you've chosen a different world.
I would be slamming the door on my family history. But also, the training in naturopathic medicine is very collaborative with conventional physicians. We have regular interdisciplinary healthcare symposiums with medical students and chiropractic students in the same town. And more there are interdisciplinary clinics which are opening up, which take use and advantage of medical doctors, naturopathic physicians, acupuncturists, massage therapists, all in the same setting. So I think that as each discipline becomes more and more secure with their own validity and scope of practice, they become and more educated as to what the other options are available. We're seeing these referrals happening on a much easier basis, and the communication is opening up, I would say, on an exponential basis right now. I'm getting referrals from medical doctors, frankly, that I don't know, but who know me because they've attended a talk that I've given or grand rounds at University of Vermont, or a patient of them has said something. So there are, you know, several of these communications happening quite rapidly.
Now, is there a generational factor here? I mean, in terms of, you know, do you get a lot of referrals from 60-year-old male doctors versus 30-year-old, you know, recently trained?
That's very perceptive of you. There are a few 60-year-old male physicians, more 60-year-old female physicians I receive referrals from, but really, truly, there is a generational aspect.
So the more recently trained younger physicians, male or female, may be a little bit more willing to explore different...
There's really no doubt about that.
I mean, seriously, there's a lot more courses, I think, today in medical schools, right, about alternative medicine and tradition, I mean, you know, natural. I think it's actually becoming parts of curriculums.
1/3 of the medical colleges now in the United States carry some type of course in complementary medicine. It is usually an elective course, but the fact that it exists at all is telling us that you know, they're taking a look.
So they can perceive this as part of their training, that they were actually exposed to this in medical school, and that so therefore it must be okay to look. I mean, I think that's a real achievement that it's actually part of their curriculum.
Right, and I do want to point out that there are usually survey courses that introduce
Right.
somebody to a discipline, such as this show today would be one course.
Right.
And it does not train a medical doctor to
Right.
be a naturopathic physician or to prescribe herbs. And that is a perception in the community that I think that we have to be careful for. There are a number of very well self-trained medical doctors who are very popular and have a high profile right now in the country, who are teaching naturopathic or natural types of therapeutics and training other professionals in weekend courses or week-long courses or weekend training programs. And then the perception for the general public is that if an MD has had a weekend course in herbology, that they must be an expert
Right.
in the herbal medicine,
Right.
which is not true at all.
Yep.
And I think that a model that will work better for us in the long run is if the people who are professionals in their own disciplines and specialists in their own disciplines really learn how to cross-refer and learn what each other does. So these courses in the medical schools are introducing the medical doctors to what is out there, teaching them when it's appropriate to make a referral to a
Right.
naturopathic physician or an acupuncturist or massage therapist, and what to expect from that referral or relationship. But it's not training the MDs how to
Sure.
do natural medicine.
Like taking a weekend course in cardiology, right? It's not exactly the same as being a cardiologist.
It's not exactly the same. I wouldn't trust my cardiologist if that was his training.
We're going through our time quickly, and you brought some things. We want to talk about the panel discussion, and you brought some things to show your medical bag and some medicines there that maybe we should focus on some of the tools of your profession.
Tools
here.
of the trade. I thought I would just bring my doctor bag and see what's in here, so that if you go to see a naturopathic physician, you know what to expect. There's nothing very strange or odd in here. You'll probably wind up with some kind of physical examination that includes the use of a stethoscope, or
Right.
maybe a reflex hammer, or an otoscope, perhaps. So there are a number of very conventional tools that we use. We also take use of conventional laboratory tests, blood testing, many.
So you, and not to jump around, but I mean, there are levels of illness that you manage as well.
Oh, absolutely.
I mean, I think that's something we haven't really talked about. We've talked about you helping to people maintain health, but there are certain disease states that you also have effective ways of managing.
The same as a general practitioner. Really, 90% of my patients do come in with a problem.
And your prescriptive authority, that's probably a topic we could spend a whole show on.
Right. Mostly the substances that we use come from the nutritional supplement world, the herbal world, and the physical medicine or manipulative medicine world.
Okay.
And I have a few examples
Sure.
of those right here. My real specialty is in herbal medicine, and I brought a few herbs to show. This is a Chinese herb called Dan Quai.
Tilt it up a little bit. So.
It's a beautiful herb. It's a very bitter tasting herb. It contains chemicals known as phytoestrogens or plant estrogens. And this is very helpful for the female reproductive cycle, especially women who are in menopause. This little herb will help to regulate erratic menses, control hot flashes, mood swings, and many of the other symptoms associated with menopause.
Now, do they do actual? How is this? And I don't want to get into too much, but I mean, there have been studies, or how do they figure this? They prescribed this for women and followed them, and
right. Well, originally this herb has been used for thousands of years in China. And the test of time has been the main proof for what types of therapies it's good for, what types of problems it's good for. Lately, Western medicine has jumped on the bandwagon to try to figure out what is in this little herb that is controlling hot flashes,
so there have
for
been
example.
some studies that actually are trying to figure out why is it effective?
Numerous studies, and most of them come out of Germany, places where these types of herbs are actually prescription items. And there is funding, therefore, for the study of herbal medicine. This is one of the problems with the lack of funding for studies in this country. If it's not a prescribable item, it cannot be patented, and there's not a pharmaceutical company who can afford to invest the $15 million it takes to to do the studies to put a drug on the market.
Okay.
So we borrow a lot of our information from the studies done in Europe and especially in Germany. The studies in Germany have shown the chemical constituents of this plant contain a large number of chemicals which actually bind to estrogen receptors in the body.
Wow.
And they activate the estrogen receptors, and that's how they help to control hot flashes. Now, it can be prepared in a number of ways. If you're very brave and hardy, you can crunch it up and make a tea out of it.
Okay.
Simmer it for 10 to 15 minutes. I don't recommend that with this particular herb for most of my first-time patients especially.
Okay.
Other options would be to put it into something called a tincture. This is a tincture of another herb, milk thistle, or Saliba marianum. It's an alcohol extract. The alcohol extracts and preserves the medicinal constituents of the herb, and it can be delivered in drop dosage form.
Okay.
And a third and perhaps most convenient way that many herbs are utilized are in capsule form. And here is an echinacea golden seal blend. And many of our viewers will be familiar.
Yeah, echinacea is a very popular, is it an herb or?
It is an herb.
That
Purple coneflower. It's a very popular garden herb actually in this community. And this is the dried, powdered, and encapsulated root of both the echinacea plant, the purple coneflower, and the golden seal.
And that's taken often when you're starting to feel cold symptoms, flu, whatever. I mean, you're starting to feel a little under the weather.
Yes.
And it has sort of properties that have been purported to boost your immune system,
That's
basically.
right. Both of these herbs actually increase the function of natural killer cells, which is one of a type of cell which attacks virally infected cells in the body. It's been shown that both of these are antivirals. One of the nice things about herbs is that there are a number of herbs which work against viruses.
Right.
And this is unique because conventional medicine, that is rare to find a substance which actually is effective against a viral cold or flu, for example.
Right.
And the herbs are an effective and safe way to treat viral illness, upper respiratory infections, etc.
Yep. But I assume that rather than someone just going out and buying these and starting to take them, that they should seek the advice of someone who has some training and how these are properly used before they just go to the health food store and start loading up on various herbs and.
If it's your first time and you're not familiar with the use of these herbs, definitely come in and see either a trained herbalist or a naturopathic physician who can guide you and will also teach you, remembering back to the doctor as teacher motif, how to take care of yourself should this come up again in the future, should you run into a cold or flu in the future.
We only have 3 minutes left, so we need to get a word in about the health fair on Saturday, May 9th, 1998 at the Hannaford Career Development Center. A whole range of, from 9 o'clock in the morning till 3 in the afternoon, a whole range of health activities, exhibits, workshops, traditional, natural, all kinds of information to be delivered. You've put together a very interesting panel discussion that, why don't you just give us a real quick 1-minute overview of what it's about.
Natural and conventional medicine working together is a discussion that I think needs to happen and to continue to happen in this community and is happening all over the United States. And we've put together a panel of professionals from many different disciplines. This will be moderated by Dr. Alan Ramsey, who is a professor at the University of Vermont School of Medicine in the Family Practice Department. Kathleen Scacciaferro is a nurse who manages the post-anesthesia care unit at Fletcher Allen, and she also practices healing touch, which is a relaxation discipline. Dorothea Manili is a licensed acupuncturist here in Middlebury. John McPartland is an osteopathic physician here in Middlebury, and myself, naturopathic physician. We will be presenting our various disciplines, and then we will have a panel discussion regarding how these medicines overlap, how to refer back and forth. Patients who are interested in using one or more of these types of medicine in addition to their conventional care can come and ask questions about how will this work with my conventional care? Right. Will my conventional doctor approve of this, and how can I get these folks to work together?
So it's sort of a longer version of what we're trying to do here this morning, with the opportunity for people to actually interact with folks like you and the others on the panel to ask the questions that maybe I'm forgetting to ask or that we don't have time to ask here this morning, and really participate in this conversation that you and I have sort of started.
That's right, and we invite both the public and providers of
Yep.
medicine to participate in our discussion.
388-4760 to make a reservation for the panel discussion, learn more about the health fair. Thank you. We're out of time, 20 seconds to go, and I want to thank you for coming this morning, and it's been very informative, and maybe we can have you back again in the future.
I'd love to come back. Thanks for having
Thank you,
me, Ron.
Lorrlee. Thanks for joining us today in Health Matters, and we will see you next time.